Dr. Muhammad, thank you very much. This is, I know, a very tedious part of how to put guidelines, but for us clinician, what's important is the conclusion. Should we ask the patient to pay money for activation without any scientific background? That's what's important for us in the guidelines. الأستاذ دكتور عمر هيبتدي البانل ديسكشن بليز.
Good evening, everyone. Thank you. I'm honored first to stand here among this great panel and this great audience. Today we're going to discuss what have been done in the IVF guidelines in a sort of small panel discussion. So far, I do have nothing to disclose. First, our panelists, Professor Gamal B. Abu Surur, Professor Ahmed Darwish, Professor Muhammad Yahya, and my dear colleague Muhammad Fawzi, and myself is Omar Shaaban. We hear a very small introduction. We hear from Professor Gamal how we are in need of developing guidelines. There is a lot of need. First, we should agree all together that we are in need of guidelines. In Egypt, we are in need of guidelines. Why? We can adopt, you can say you can adopt any of the guidelines of the ISHRI, of the SRM, of anything. I think that the circumstances in Egypt and the financial constraints that affect the IVF practice, availability of drugs, availability, the religious aspects of the patients and of the couples, shows us that we are in need of our specific guidelines. There is fears from litigations and restrictions of practice from developing these guidelines. But we should say that guidelines, like any guidelines in the world, you can stick to it. You can violate the guidelines sometimes if you have enough reasons to go that. Target of this session is mainly educational. We are not speaking about any political things. I went through the documents that have been finalized and choose certain points to discuss with our panelists. And if there will be enough time in each point, I will allow one or two questions from the floor. Let's start immediately in the guidelines. What have been completed, as I have been informed from Professor Yahya, is embryo transfer guidelines, ovarian hyperstimulation syndrome, artificial oocyte activation, the one Muhammad had been summarized in the recent presentation, and special guidelines for the number of embryo to transfer. In progress, diagnosis of infertility, induction of ovulation, semen analysis, adjuvants, and indications of the IVF. These are in the pipeline. What I have said, what I'm putting here is statements from the guidelines we have finished and published in the University Council guidelines, and I will ask the panelists to comment on these points. First, it is recommended that the clinician should perform single embryo transfer. And here I will put all things that's related to the number of embryos that are going to be transferred together. Three statements are there. The first one said it is recommended that clinician should perform single embryo transfer. The second, up to 2 embryos could be transferred in the uterus in certain cases. And the third, that the transfer of more than 2 embryos with intention of performing fetal reduction in case of multiple embryo implantation. These are the two statements in the guidelines. I will start with Dr. Yahya Professor Yahya, your comment about this specific point, number of embryo transfer as reflection of the at the reflection of the guidelines and of this.
هو number of embryo transferred, what we have put, it's recommended for the clinician to perform single embryo transfer. وقايلين امتى first trial, good prognosis patients, less than 35، كل ده جاي متفسر. up to 2 embryos احنا عارفين الترانسفورميشن هيبقى very difficult في مصر، بالناس دلوقتي بيحطوا 5 واكتر. ل a single embryo transfer might be difficult. فقلنا it is up to 2 embryos can be put in the uterus. لكن في نفس الوقت حطينا في الاكسبلانيشن ان الايفيدنس بيقول العيانين في جزء منهم في compulsory single embryo transfer. If you perform more than one embryo في العيانين دول، عيانه عندها unicorn uterus، عيانه عندها history of premature labor، عيانه عندها gestational diabetes، كل العيانين اللي هم contra indicated فيهم ان هم يبقى عندهم multiple pregnancy. الباراجراف الثالث اللي هو you cannot just put any number of embryos وبعد كده تقول للعيانه ان انت هتعمل لها fetal reduction، لان fetal reduction by itself carries a lot of risk. فده it doesn't make sense. احنا في الجايد لاينز حاطين ان up to 3 embryos can be transferred after 40 years او in specific situation. انما مع كل واحده من دول لازم بنشرح للعيان نقول له what are the complications. الكونسنت فورم بتاعنا لازم يبقى مكتوب فيها ان if you put more than one embryo you are liable to have multiple pregnancy with all its complications. فهي الفكره ان هو زي ما الاستاذ الدكتور جمال قال، هو الجايد لاينز معموله to protect us من المشاكل. يمكن النهارده الدكتور اسامه اتكلم على قانون المسؤوليه الطبيه. هو طول ما احنا بنشتغل جوه الجايد لاينز you are protected by the guidelines. انما حضرتك هتعمل حاجه against the guidelines you have to be prepared to defend yourself. That's the whole point.
دكتور عماد بيه، هنطلع سنه من الجايد لاينز واقول لحضرتك in practice او in your practice when you are going to transfer 3, 2 or 1 embryo.
The first important thing in our practice is counseling. Counseling should be done in a very clear way and in a very honest way for the client, because I was speaking with Professor Bulgar just before this session. Should be very clear for all the clinicians and for all the clients that in this practice the failures is expected more than the success. This is a very important point to be clear to the client. أنا هرجع لك بس الأكثر إن أنت مش هتحملي. للأسف إحنا في الكونسلنج في مصر بيتقال العكس، وبيبقى غريبة جدا إنها رجعت after embryo transfer and she didn't get pregnant. She came back to you screaming and asking why. Counseling will protect you. This is the first important step. Then in my own practice, I should be very honest with myself when, of course, as Professor Yahya told, with good prognosis cases, first case, young, uterus is very good, no anomalies, no endometrium is perfect, she is in the 20s or early 30s, high quality embryos, I prefer to transfer single embryo and freeze the rest.
Dr. Gamal Bey, we know that many of the international organizations and many of the countries does prevent transferring more than one embryo. but we still, in most of the centers in Egypt, we are usually transferred 2 or 3. Yeah, I need to know from your distinguished self that بالعربي كده, why in Egypt we are thinking about transferring more than one embryo? What is the logic behind the Egyptian mind of transferring more than one embryo? Is it financial? Is it something related to the quality of the centers? Why?
Thank you very much for the very difficult question. I think the answer is because we are concerned about the positive pregnancy test and not the live birth rate.
Again, please, because we are seeking for positive pregnancy.
For positive pregnancy test, unfortunately, and we are not thinking of the outcome. We are not thinking of the live birth rate. And consequently, all the misinformation which is present in the public, it becomes very pressing for the patient when you are counseling her about the number of the embryo to be transferred. Having said so, then certainly to decide on the number of embryos to transfer, we have to take into consideration the age of the patient, the previous outcome of any previous treatment like IVF before, also the quality of the embryo, which day are you transferring the embryo, the 3rd day or the 5th day, whether you perform a genetic assessment of the embryos or not. If you did NGS for the embryos and the patient is young, certainly you can transfer single embryo. And I do counsel some of my patients who have one child and they want to have another child on this because with the increased expenses of living, they don't want to have more than 2 children. So I counsel them, and if they agree, I do transfer one embryo. However, this number is very little actually among the public because the acceptability for the public is very low. But as I mentioned, I depend on the counseling of my patient. I tell her, if I transfer 2 embryos, you will have a higher success rate. But if I transfer one and freeze the other one, then still, in spite of the fact that you get a lower pregnancy rate with single embryo transfer, but you still have another embryo which could be transferred later on. And these points has to be made very clear for the patient. And the counseling of the patient is the whole mark in this issue.
Thank you, Muhammad. It is propagated, especially in Egypt, that single embryo transfer is only made if you did a genetic testing. Is this the recommendation of any of the international society that if you are going to transfer single embryo, it should be genetically tested?
The American group in general prefer to do genetic testing, but it's not a must.
But most of the guidelines says no.
No.
This does not increase pregnancy rate. Genetic testing having a special position. عاوزين السلايدز لو سمحت. Transfer under anesthesia. Comment? Yes, sure. We can allow 1 or 2 questions. حاضرين مايك هنا لو سمحت.
I think the cost of freezing is very important. The financial reason, the financial burden on the patient. If we think about the freezing one embryo in one straw, in our country we freeze up to 5 embryos or 6 embryos on one straw, which to save money for the patient. If it is cheaper, if we can manage to make it cheaper to freeze one embryo in one straw and transfer one embryo, only one embryo, I think, but because it's very expensive, if I transfer 2 embryos, then I will save the patient a lot of money. So the financial burden in our country force us to transfer 2 embryos. This is, and I think most of our centers transfer 2 embryos rather than one embryo.
So Dr. Shaur says that the transferring 2 embryos, because we are freezing the embryos in collective straws, in 2 or 3 straws. دكتور يحيى هذا comment.
Definitely this is understandable. بس نرجع تاني رأي الدكتور جمال. هي البوينت ان هو تيك هوم بيبيز قد ايه؟ يعني كلنا عندنا حالات توينز ابورتد، والمشكله مش الابورشن، المشكله لما تولد في 29 اسبوع والبيبي يفضل في الحضانه شهر ونص ويخرج بمشاكل. يعني انا I can quote figures very recent unfortunately it's my case. يعني عيانه ولدت 31 اسبوع توينز، الحضانه لغايه النهارده البيبي بقى له شهر ونص حسابه 2 مليون جنيه. فهو كان افورد ذس؟ لما تفكر فيها ان الفريزنج اوف وان سترو، ما هو we have to think about the other spectrum. وانا زيك بقى yield under pressure. يعني العيانه عندي 35 سنه وبلا بلا بلا، فبتقول لها وبتعمل كل حاجه، انما في الاخر خالص you yield under pressure.
So the financial burden حضرتك بتوفرها هنا like it will be increased in the twin pregnancy complication.
هو in a very simple words for the patient, for the client, we tell that once you have a multiple pregnancy, you change it from normal pregnancy to high risk pregnancy. فيقول لها بطريقه واضحه كده، انت اول ما حملتي في توينز اتنقلتي من الحمل العادي للحمل ذو الخطوره المرتفعه. These words is very effective as during the counseling, and you should be very clear. As regard freezing more than one embryo, yes, you can freeze more than one embryo, and if she didn't get pregnant in the first transfer, in the second transfer you can allow it to transfer two embryos.
Dr. Khaldun Sharif, Mike, please.
Thank you for this beautiful and informative session. Regarding this point, I go back to Professor Surur, very excellent point about not legislate because laws will take a very long time to change if they change. The only point I would take an exception from that is the number of embryos transferred. If the law says no more than 2 embryos, for example, then you would simply say to your patient, oh, okay, you are right, I agree with you, but we cannot break the law. And that will give you out. Jordan, just on the 1st of October this year, we had the law coming out, and it organized some basic things like the qualification of the doctor doing the IVF, the qualification of the embryologist, and the number of embryos. And they were clever enough not to go into the other details because they changed. But all of us would agree that qualifications are constant. You have to be qualified.
What they are saying in Jordan about the number of embryo transfer?
They said exactly like you said, gentlemen, is maximum of 2 under 40, maximum of 3 over 40. And they left it as simple as that. So, and all of us would agree at more or less. So that would get you out of being coerced by the patients, as all of us are. Thank you.
Thank you very much.
Sharif, I just want to tell you we are قانون ال IVF في مصر هيطلع very soon, and I can assure you what you said is being incorporated in it.
Thank you. دكتور أبو عمر، اتفضل يا فندم. Mike, please.
Of course, we should follow international regulations, and any guidelines should not be different from the whole world. And the whole world says that a transfer of a single blastocyst transfer is the ideal, with few exceptions in certain age groups or previous failures and so on. So I agree with this assumption that this is good. But why guidelines are made different in different countries? Because different countries have different situations. If we want to make any law or any guidelines, we should know that it is possibly applicable. If we know for sure that in Egypt, very few people or ever, and for very few patients who transfer a single embryo transfer. So why should we make bylaws we know from the very beginning that nobody will follow? We should make a reasonable bylaws that 2 embryos and you better transfer one blastocyst transfer in young patients, but don't make two embryo transfer as not right. If you transfer two embryos and the patient gets twins and premature labor and she has a problem, she can go to the court and win the case because the guidelines of Egypt say don't transfer two embryos. So let us be logic and also consider the world. We don't go away from science and the world. And thank
دكتور
you very
محمد
much.
ده اللي حضرتك بتقوله بالظبط هو اللي احنا دكتور محمد حضرتك اللي بتقوله ده هو اللي احنا عاملينه. هو احنا قايلين ان up to 2 are
To Eileen and transfer one blastocyst transfer.
is recommended. ممكن نجيبها لو سمحت.
And this is very vague.
لا دي واحده يا دكتور محمد. It's very clear. It's very clear in the recommendation. كويس؟ الريكومنديشن اللي احنا حاطينها بتقول ايه؟ It is recommended to transfer a single embryo. However, up to 2 embryos are permissible.
Yes, are permissible.
فهي النقطه هنا
Are permissible but not preferable. So
ما هو
if
حضرتك
it is not preferable, then the patient can win the case against.
لا يا بيه.
Yes, it is not, because you should do what is advised, not what you can possibly do.
يا دكتور محمد هو حضرتك احنا practically حاطين situation وقلنا دي compulsory single. انما بعد كده it is permissible. permissible هنا معناها you didn't do a crime. وقايلين 3 embryos after 40. يعني ال 3 scenarios محطوطين زي ما هم كده. اللانجوج اللي احنا اخترناها ده جت بعد legal representation. واحنا اللي احنا نعمله كطلب زملاء كتير قوي ان احنا هنكتب في الكونسنت اللي بيتكتب بالظبط ايه الكلام، وهيتراجع عند محامي بحيث ان اللايبيليتي ما تبقاش على الدكتور اتاني كيس. انما هي البوينت ان هو احنا ما جربناش 2 لم يحدث.
I think
I would like بس هنا ان احنا نفهم ان there are 2 documents are prepared. The IVF law and the guidelines, and they are completely different. The IVF law does not say something about single embryo transfer.
بالظبط. القانون يا دكتور محمد ليس به اي كلام عن سنجل. القانون دي واحده يا دكتور عمر، انا عايز اوضح حاجه بس. القانون يا دكتور محمد كاتب 2 embryos. يعني القانون وده لسه ما طلعش، انما القانون فيه 2 embryos وحاطين فيه انه اللائحه التنفيذيه ممكن تختلف، فحتى مدين للدكاتره اوتلت عشان ال 3 embryos تتحط في اللائحه التنفيذيه، لان اللائحه التنفيذيه تغييرها ممكن يبقى اسهل. انما هي البوينت ان هو حضرتك عايز نشيل certain cases.
لا انا دلوقتي احنا دخلنا في القانون، فانا
أنا مش داخل في
you
القانون.
mentioned now that there is a law about to come, and as Professor Su mentioned, law will be a catastrophe, will be a big catastrophe for every doctor in Egypt, because to make a law you have to work 10 years before. You have to register all IVF center. All IVF center should first start voluntary reporting everything. And this takes 2-3 years, as it was done in England. And then after 3 years, you make it compulsory reporting. And then you make how to monitor, how to visit the center. This is after. But if you make a law today, it will be like all other laws in Egypt. It is there, but nobody follows them. If you want to do this, do this.
دكتور محمد هو we cannot go from one extreme to the other. هو اللو to have a law for IVF is actually أنا في تصوري is very important. دي واحده يا دكتور محمد، بس ثانيه، اصل احنا هنخش في انذر. طيب ممكن نحط يا دكتور محمد انذر ميعاد لانذر سيشن نناقش الميريت اوف ذا لو.
I should move because of Dr. Shalani will kill me. I should move to complete the session. I know that this is a very hot topic, but I would like to explain that there is a difference between the law and the guidelines. The problem that are both initiatives comes together. So there is some mix between that. What we are talking about today is not the Egyptian law of IVF. We are talking about the guidelines for IVF, not speaking about the law anymore. So hold the discussion about the law and let us complete our session, please. Dr. Ahmed, to move, I would like to ask you specifically, in our guidelines, evidence-based, there is no need of anesthesia during but I'll ask you specifically when you are transferring under anesthesia. What are the patients that you are electively say that this patient I will go to transfer under anesthesia? From your experience.
I think it's very easy. First, when we do a mock transfer in the very initial examination, you should make a mock transfer with an empty embryo transfer catheter. If you find difficulties, consider it.
But most of the people are transferring, doing the mock under anesthesia during ovum pickup.
No, no.
So
I'm not during pickup. I'm in your clinic.
In the office, yes.
In the office, when you see the case for the first time during the regular gynecological examination, which should be done for any patient, for any case. And if you will decide that this case will go for IVF, you make a mock transfer, keep some sterile used catheters in your clinic and try to do it.
Dr. Ramzi.
وبعدين you make another one at the time of pickup. وفي certain types of patients, you know that they are very apprehensive and they cannot tolerate doing the transfer without anesthesia.
Dr. Ramzi, تفضل.
لا I'm said used sterile.
ازاي استعمل في العياده تستر ب 1000 جنيه عشان اعمل بيها موقع؟
used sterile one. Used the used.
Where do I get the sterile او the sterilized مش السترايل اللي الدكتور عماد حضرتك قلت سترايل ب 1000 جنيه. ريسترايزيشن المركز بيخليها عنده، مش هيديها لي.
لا
ومش هيديها لده ومش هيديها لده، اجيبها منين؟
You can ask, this is not an easy. يعني اليوزد كاستر في كتير قوي.
من ايه؟
من المراكز.
من المراكز هتخليها في المراكز.
هي المركز هيعيد استعمالها مع جديد.
هيعيد استعمالها عشان الموك.
وممكن يبقى عنده كتير يعني مش للدرجات دي يعني كلنا عندنا.
طيب حسن دكتور محمد حضرتك do you ever think about doing transfer under anesthesia after multiple implantation failure? Okay, I'd like to hear it.
هو البوينت اساسا انا ما بعملش موك. يعني
You think that the mock is harmful?
I don't think. يعني اولا let's be frank, unless ان الواحد شايف في الالترا ساوند ان في حاجه انجل اكيوتلي انتيفيرتد او بتاع، ف you don't need to do a mock لان اليوترس by the time of stimulation is totally different عن النون stimulated uterus. الحاجه الثانيه ان احنا كلنا دلوقتي بنشتغل اندر الترا ساوند، فانت actually شايف، ف there is no point in doing mock unless there is a problem. أنا in my book الapprehensive patients لا هو at the time of the transfer هتستنى العينة وتاخد انستيزيا، مش هيحصل حاجة في الدنيا. انما ايوه هتستنى 3 ساعات، هو بتاخد كلير فلويدز يا عماد. انما definitely you are احنا بنتكلم في 1 point single point عشان نخش في الامبري
anesthesia during transfer.
Anesthesia during transfer is not preferable.
In a touchy ladies. We can say in the touchy ladies.
طبعا
That in the touchy ladies. No other indications.
No.
Okay, let's move to the next guidelines that have been developed for the sake of time, which is the ovarian hyperstimulation. And my question to Professor Surur, and I know that he shared in the preparation of this document about ovarian hyperstimulation. On my specific question about the outpatient management, what are the criteria that you choose for managing this ovarian hyperstimulation lady as an outpatient?
The criteria for management of ovarian hyperstimulation at home, that's if it is mild and moderate ovarian hyperstimulation, if the patient has the facilities to come back to the center for a checkup, there are no problems in her coming back. She doesn't live in a far away city, away from Cairo. And when she comes up, we follow up her and see how she is going. If she is improving, well and good. If she deteriorates, then this will be shifted to hospitalization. That's if she deteriorated, but which is very unlikely if you properly choose the patient whom you decide to treat at home.
سؤالي هنا برضو لحضرتك you are doing this home management سواء حضرتك she's transferred this cycle or she freeze all or if you transfer you prefer to manage it at hospital.
Well, actually in both, but the likely that the fact that she will develop a severer form if I froze all is very, very little indeed. But if you did fresh transfer, yes, you have to follow her up to make sure that everything is
So
okay.
freezing all will allow you more to be more generous in
More
allowing
generous,
the patient to be
absolutely.
managed at home.
Absolutely, yes.
Okay. Can you, Dr. Ahmed Bey, can you describe if you are going to manage this lady at home, what you are going to tell her? What is the type of counseling? انت لازم تعملي ايه؟
Excess fluid intake,
Excess fluid intake,
monitoring urine output. If you have any difficulty in breathing, abdominal distension and severe pain, swelling legs, all these signs, symptoms should be watched, and if she develops any of this, she should come back. And there should be regular checkup. Yeah, don't leave her that, don't come again. Of course, there you should see her regularly and do some laboratory tests. In my opinion, the most important one is the hematocrit value. I consider it very important. If it
are
is
there a cut-off value of a hematocrit you should admit the patient to hospital for intravenous fluids?
I think it is 45, 50, you should admit and give intravenous fluids.
Okay, let's move to the final guidelines that have been finished related to the artificial oocyte activation. Muhammad had been summarized this to us. For those who are not here during this, as I understand, Muhammad, artificial oocyte activation is the method to deal with those with poor fertilization. Certain patients with poor fertilization, there are different techniques you are using for activation of the oocyte for fertilization. Can you summarize 1, 2, 3? What are the methods and what is the preferable methods as far as you find in the guidelines?
Oocyte activation is the method that we can use to artificially enhance the fertilization. Theoretically, it can be done by electrical, mechanical, or chemical. Nowadays, chemical is the most used procedure.
What type of chemicals, Muhammad?
It's calcium ionophore, which include ionomycin, calcimycin, and the other
What are
items.
the type of patients specifically we as the clinician should counsel them that an additional procedure is going to be done for them?
Yeah, there is what we found that patient with low fertilization could consider artificial
Previous
oocyte
low
activation,
previous
low
low
fertilization.
fertilization, you
But I would like to say why we used could here, not should, because it only supported by evidence enhanced fertilization, and fertilization by itself is a surrogate outcome. It's like implantation in clinical. So we didn't find any evidence that artificial oocyte activation, even for this subgroup, will enhance the clinical outcome up to life birth rate, clinical pregnancy, etc. So if you believe that fertilization it is an important for you as an outcome, you could use artificial host activation for this subgroup. After we finalized this recommendation, we stopped using artificial host activation in our laboratory.
Muhammad, can I promise, you need my last question to you. Can I promise a couple with poor fertilization that I do have any new method of activation of the oocyte that can improve their outcome?
No, we can't say that because this is not guaranteed, and statistically.
As far as as far as me as a clinician and as far as I'm counseling the patients, I should not speak with the patients about artificial oocyte activation.
Yes.
Okay, let's. Discussion is very nice, and I'm very happy with discussion with you. But there is a limited time for our schedule, and we should conclude this session. Thank you very much.